Welcome back to the Pastore podcast. It is still May, so we are following on the topic of Celiac Disease Awareness Month. And this is for those that have been diagnosed with celiac disease, but something's not right yet. So the topic that we're talking about is refractory celiac disease. So Dr. Pastore, I would love for you to tell me what that is.
Refractory celiac is actually identical to celiac disease, but what's fascinating about it and where it starts to differ is that the patient is, or at least we seem to think they are 100% non-responsive even after they've been on a strict militant gluten-free diet for a period of 1 year.
1 year.
And that's 1 year. So that's typically when you start to get very questionable, as you could imagine. You remember our past episodes where we talked about my view of how you should follow up. So we're talking about this beautiful story of month 3 or 6, and then month 12. And at month 12, you're getting a better picture of your health and all your antibodies are normal. Well, imagine these poor souls all show up and nothing's normal. So that's the first clue that something could be wrong. But I do want to talk today, Lexi, about how we need to make sure it's real. And I want to talk about that type of aspect and how we go about examining it. But for all intents and purposes, you're diagnosed with celiac disease and you are not recovered after all the proper care after a full year of time.
And if you are wondering what that full year of care, the 3, 6, and 12 months that Dr. Pastore was talking about right there, we will include a link in the show notes to the article for as soon as you get diagnosed, what you should continue to follow up with your physician about in that year. So the 12-month mark has come around, Dr. Pastore, and they're going to see their physician. How is refractory celiac disease diagnosed?
And that's a great question, and thank you for that. And this is where I now know, and I'm putting myself to the fire to make sure I get it done promptly. There needs to be a blog article on this. That's a step-by-step instruction. Because we talked about in the past how difficult and challenging it can be for physicians to even understand and properly diagnose celiac disease. Imagine the minority of this condition known as refractory. So please let me share my expertise here, and I'll rely on some of the classic medical texts, but you really have to be in the know to understand this. And for our regular listeners, I have celiac disease, and I actually just worked on and helped resolve a case of refractory celiac disease. So first, it is my clinical opinion that it must be evaluated as part of a diagnostic process. So I guess you could say my view is that refractory celiac disease is actually diagnosed by a process of elimination during an extremely thorough medical examination. Please let me explain. I promise you I only have 6 points that are very fresh in my mind because I just wrapped up this extremely difficult case where I was working as a team of 1 of 4 specialists. So first, and here's where I came in, you have to really review all of the original diagnostic criteria for celiac disease. So I mean a deep dive going back as far as you can in the patient's medical records to get the original biopsy, the actual serology, which means the blood test that we use for the diagnosis.
Which we talked about last week in our episode.
And you know how intense that is, right? So I'm not kidding you. In this recent case, I had to track down 15 years ago of data. So I had to get all of that, get the original films, get everything for the diagnosis of the patient's celiac disease, and then hope that there was some DNA done. If that wasn't done, I want that. I want all the factors that prove without a shadow of a doubt this indeed was originally celiac disease. And then I needed very intense confirmation that the patient has followed a strict militant gluten-free diet for a period of a year, but they definitely still had symptoms and they still have villi damage.
And you mentioned with this patient that you had to go back 15 years. So this was a diagnosis that happened 15 years ago, and they still were experiencing refractory celiac disease?
Yeah, so the patient was never well, just never, and it's sad that you have to have that cutoff of 1 year, and the decade the diagnosis for celiac disease can take over, in my humble opinion, it's over 10 years for me, right? I say the decade of diagnosis. I was diagnosed from birth to around the age of 19, 20, so a real long time, and I've met a lot of patients. The average age, I'm going to say now, is between 9 to 12 years, so this poor individual was suffering for a period of well over 12 years. finally gets a diagnosis, and I had to go back to the date of diagnosis, which was 15 years prior, but the patient still has been suffering. And sadly, like many people, they slip through the cracks when you don't have enough sleuthing or detectives on the case, so to speak, right? It's like an old case, it's closed, it's celiac, classic.
Talked about physicians and their lack of awareness so many times on this podcast. So it's, okay, well, you're celiac, are you following a gluten-free diet? Yep. Okay, well, that's probably not it. Let's figure out what else it is. And they just brush it off.
Correct. And that's not a good thing, right? Because you want to make sure that the patient has full support. And we talked about all this after diagnosis and what to do. We talked about it on our podcast episode about how to properly follow up. And I talked about the whole support system, having your regular visits with a certified nutrition specialist or registered dietitian that's an expert in this field, in addition to the medical care, even therapy or psychological evaluations and help to get you through the massive diet transition. But you need to be tested. So we prove you're not exposed, right? Because we talked about that. Regular tests to prove that there was no exposure. You really indeed are gluten-free. And I'm not talking about the few cases I mentioned on this podcast where I was exposed or air quote punked with gluten and then was symptomatic. I'm talking about regular exposure that leads to long-term destruction of the villi and microvilli. So it's so important because if there's any blip in everything I just mentioned so far, remember I have 6 things to mention. So in point number 1, if any of those things don't line up right, it almost instantaneously rules out refractive celiac disease. So is it a real diagnosis? Was it biopsy positive? Where's the films and impressions and report on that? What was the blood work that was done? Is the patient a genetic carrier? Those are so amazingly important. And you might say, well, hold on, how often can you get all of that information on a potential refractory celiac disease case? I'm going to be honest, not very often. And a lot of times I have to try to patch it all together. And the best place to start is the genetics, because if you don't have the genetics, I'm in a school of thought of individuals, and I'm proud to say like University of Chicago and the Mayo Clinic, et cetera, that believe if you do not have the genes, you cannot have the disease. You can have other diseases that can basically mimic celiac disease. So let's go find those. So that brings me to point number 2 that I want to mention, which is really doubling down on identifying any other condition that can negatively impact the villi, including cancer such as intestinal lymphoma, inflammatory bowel disease such as Crohn's disease. People don't realize that even though Crohn's is so far down in the large intestine, it absolutely can interfere with and damage the small intestine. There's
now,
also something.
Crohn's and celiac at the same time?
Yes, and I have seen that in practice. Yeah, it's pretty sad. And you probably could guess this, but long untreated, undiagnosed celiac disease can actually end up causing Crohn's disease. So the good news is I've worked on cases where I said, oh my goodness, this is Crohn's, but I still want an upper GI. And then I get an upper GI, and that means where you do a scope. I'm using slang terms here. You get an endoscopy, and they put a scope down your throat and your esophagus into your stomach and past that into the first part of your small intestine, and they get some biopsy samples, and they can also look around a bit. And in those cases, I was able to confirm, of course, led by proper blood work, as I always talk about, I was able to confirm, hey, wait a minute, that first diagnosis is actually the second diagnosis. The first diagnosis is this one, celiac disease. So now we're treating the patient for the second diagnosis, and they're not getting well because they actually had celiac disease causing the Crohn's disease. Wild. But of course, Crohn's lives independently of celiac disease. I just wanted our listening audience to know they can actually breach into each other, unfortunately. So that's one of them. There's another condition known as microscopic colitis. That's a separate type of condition. It's a subclass of something called ulcerative colitis that differs from Crohn's, but it can also be a causation. Believe it or not, Lexi, and this is the case that I was able to work on just recently, there's something known as hypogammaglobulinemia, which is where the immune system doesn't even produce enough antibodies. And then those antibodies are called immunoglobulins. We talk about those on this podcast. And that can result in an increased risk for infection. So in this one case that I had, really true, real deep embedded small intestinal bacterial overgrowth, if severe enough, can damage the villi and microvilli and make you believe this patient had celiac disease. The patient did not have celiac disease. and they actually had small intestinal bacterial overgrowth that was severe. It was actually diagnosed on a biopsy, not a breath test, not any other type of test. It was a full-on biopsy inside the lumen of the small intestine, and we were able to identify that and then treat that and basically abate all these symptoms. Also, and this is pretty shocking, still on point number 2, you can actually have a severe reaction to an over-the-counter non-steroidal anti-inflammatory medication. And then you could also be an abuser of non-steroidal anti-inflammatory medications, meaning
now,
you take.
can you just clarify what those are for listeners that aren't 100% sure?
Yeah, acetaminophen, Advil, Tylenol, all of those specific over-the-counter pain relievers that don't require a prescription that are non-aspirin are in the category of non-steroidal anti-inflammatory drugs that can give you a pro-inflammatory response for the villi and microvilli. Aspirin's still in the category of non-steroidal anti-inflammatories, but it's not associated with destruction of the villi and microvilli. It is associated with gastrointestinal bleeding, which is a completely different thing, which is why I was hopefully separating the nomenclature. Also on this path to evaluation, so you got number 1 done, you got number 2 done, you also have to perform number 2, you should have a full endoscopy and colonoscopy. Even though the doctor will see in the patient's history, they already had the endoscopy to get diagnosed with celiac disease in the first place, you want to repeat that now, and you also want to get a colonoscopy, and both sites should have biopsies. It's a very important thing. And I'd like to pepper in for my 4th point that one of my favorite things to do here, and this is pretty new and it's really awesome, is I love a capsule endoscopy. So you're basically swallowing a really cool camera and it's really tiny, and it gives us these amazing 3-dimensional pictures. So it's a camera in a pill format, and you can get excellent images, and you can identify some inflammation and ulceration. It also helped me crack a case of jejunal inflammation and ulceration, which is the second part of the small intestine. You have the duodenum, the jejunum, and then you have the ileum. Well, that middle part, if that's ulcerated, it's an extreme high risk for what's known as lymphatic cancers of the intestine. So you want to make sure you can identify it. And this capsule endoscopy has been gangbusters at helping us be able to identify if that's truly in that area. The last thing that I would do for closing out the diagnostic cycles that are imaging is I really think if the doctor says to me, I think there may be some like lymphoma, I don't like the way the blood tests are looking, then we throw everything at the patient and we will use computerized tomography, which is known as a CT scan. We'll use magnetic resonance enterography, which is different than an MRI. It looks specifically at the intestinal lumen, the small intestine, large intestine. You can even see the stomach. Barium X-rays. Barium is an organic mineral. It's silvery. And what's interesting is if you give the patient that to consume, you mix it with water and they drink it, it lights up really white and 3-dimensional on a barium X-ray. Cool. So isn't that cool? So instead of just saying, hey, let me just get some X-rays of your gut, I was even talking to a physician. I said, hey, it'd be really cool if let's do a barium swallow, let's get it in the gut, and then we get this wicked, every single shape and abnormality you could find. It was actually one way about, 16 years ago, I was able to help identify a patient that had a reverse of their entire gastrointestinal tract. So everything was
mirrored?
Yeah, it was on the opposite side. It was really, really cool. And we were able to see like where the splenic flexure should be. It was on the other side, and they actually ended up having their liver on the opposite side. And as you can imagine, you never would know this until we saw the tracts and channels, and then the patient had full MRIs and scans to identify that. So it's a very cool way of getting incredible 3-dimensional, very, very clear images, and you can rule out any suspicion unfortunately, of lymphoma. Also, I'd like to warn our listeners at this point, if you know a loved one who's going through this and they go through this pathway, please be prepared for typically multiple diagnoses during the search behind suspected refractory celiac disease. You're really examining like mad here, and you can find multiple things. So use that as an empowerment that now you're on the path for this individual getting well, or if it's you, the listener, that's been suffering, you finally will get answers. And typically you get multiple things that are happening at the same exact time. And lastly, which is my 6th point on the path to diagnosis, it's really wise to measure a fecal fat at this time, because we've talked about steatorrhea as a mainstay symptom of celiac disease that's undiagnosed, and that's when you have like floating fatty stools. You can actually measure that very easily through a stool sample. And the Mayo Clinic, I know, also recommends pancreatic testing to make sure the pancreas is functioning optimally as well. So that's as aggressive as you possibly can imagine to get towards a diagnosis or rule in and out. If the patient passes through all of that and there's no other rhyme or reason through that massive battery of testing, you definitely would categorize that patient as refractory celiac disease.
Now,
And then
all
you'd
of
want,
these
please.
tests that you mentioned, when you run them, because I know you're an on-the-ball physician that doesn't let things slip, how long does this process take with all of those different tests?
Well, I mean, if you're lucky enough to get them all done in one shot, I just wrapped up a case of this exact path over a period of about a month and a half. So here you have this patient suffering for a very long period of time, and I was told yesterday that I have the power of the Rolodex. No young people would get that reference. What it means is I have an awesome network of the best in their field, and I'm very blessed that I can just call them, while they're barbecuing in the backyard and say, here's what I need. And it'll happen. So I'm really lucky. And I was able to choreograph all of that over a month and a half. And I basically acted as the primary investigator, basically the PI, right? So I acted as the primary investigator, tying all these pieces together and then making sure we tied it in a neat little bow. But once you get all of that, and then let's say, because the topic of this episode is refractory celiac disease. So Lexi, guess what? So we go through all that and we have a patient who's refractory celiac. Now we have to type them because there's two types of refractory celiac disease. There's type 1, which has a much better prognosis than type 2. Type 2, unfortunately, has a very high risk for lymphoma. And there's two very simple ways to know this. So type 1 is characterized by abnormal intestinal epithelial lymphocytes. They're actually immature, and we see that on our repeated biopsy. They're just extremely abnormal. And in type 2, definitely malnutrition is really present very strongly. But we have this major inflammatory ulceration that's also present at the same exact time we're seeing microvilli destruction. So we're moving towards
type 2 is more similar to the undiagnosed celiac then?
Definitely undiagnosed celiac with a peppering in of what would make a doctor think there's like a microscopic colitis or an ulcerative colitis, but moved from the large intestine into the small intestine. So ulcerations of areas, typically the jejunum of the small intestine, you will start seeing those ulcerations. And that's basically what I'm saying, like an ulcer. Think of a stomach ulcer, move that to the location of the middle part of the small intestine, and that is typically present in a type 2 refractory celiac disease case. By the way, I'd like you to know how rare it is. So 85% of patients who have refractory celiac disease are type 1, so type 2 is extremely far into the minority. So I just wanted to make sure that people realize type 2 is not that prevalent.
So with those percentages, most of them being type 1, let's
Right.
talk about the numbers for refractory celiac disease.
Yes.
So diagnosed as a celiac,
Right.
how many of the diagnosed celiacs are experiencing this?
I'll tell you what I have seen, and I'll give you a great quote that Harvard wrapped up. So Harvard's saying 1.5% of all celiac disease patients over the age of 50 will have type 1 refractory celiac disease diagnoses. What I have seen is around 1 to 2%.
If we're doing the math there, then 1 in 100 people are celiacs. So let's say best case scenario, it's not 83% are still walking around undiagnosed, but all the 1 in 100 have been diagnosed as celiacs. Now, 1% of those, you're looking at 1 in 1,000 people on the earth have refractory celiac disease, roughly.
Roughly, which would put it right in line with like a Crohn's disease, which is basically 1 out of 1,000 people. And again, which makes the odds more in favor of getting a diagnosis before you can identify this and you can actually hopefully do things about it, is that I'm not aware of one case in the pediatric community. So that's awesome. And typically everybody is celiac over the age of 50 that has true refractory celiac disease. So that number over the age of 50 is really important. And it really helps us zone in. And of course, I don't wear blinders, and I'm going to look regardless of the age, but I have not seen a case And I'm not aware of any cases, even the great Dr. Joseph Murray, who I talk about all the time and published with him last year, and he's world-renowned celiac disease expert at Mayo. He's got the same basis of findings, that it's typically over the age of 50.
So what are the signs and symptoms that these celiacs, typically over the age of 50, have to look for where there's a red flag that it might be refractory celiac disease?
You know, and I hope everyone would go back and listen to our episode and read my blog of all the different classic and non-classic symptoms of celiac disease. It's all of those magnified to the most severe amount, and they're just not getting any better. And that's that. And so it's sad. It's sad that it's such a simple answer. There's no new magical symptom. It's just the worst of celiac disease magnified times 10. You're experiencing it. So if someone was classically nauseous, you're severely nauseous and vomiting on the regular. If someone has diarrhea, you can't even remember the last time you've had a normal stool, and it's absolutely destroying your life. The severe impediment of celiac disease symptoms, not taking it away from the celiacs, but what I mean here is you're diagnosed and you're treated for a year and you still have the exact same symptoms that brought you to the diagnosis of celiac disease. So 12 months after the diagnosis and after supposedly militantly being on a gluten-free diet, you're still presenting with the worst version of the celiac symptoms.
And we will, again, link the symptoms, all of them, classic and non-classic, in the show notes if you guys want to check it out. Because it's far, far, far beyond just gastrointestinal issues, and it could be only one of the other symptoms.
100% correct, yes.
So is there a physical difference between celiac disease and refractory celiac disease?
Yeah, and I kind of alluded to it, and thank you for tying it up so that I can make it really clear. In some refractory celiac disease patients, there's these reports I talked about of this ulceration of the middle part of the small intestine, and that's known as ulcerative gingivitis, and that's very serious. I can't make this clear enough. It is a fast track to what's known as a risk for T-cell based lymphomas. And what I'm saying in English is a small intestine cancer. And it is a huge warning sign. Every doctor who would see it would treat it very aggressively. They would be on top of it in a minute. The problem is the only way to actually get that understanding is through the aforementioned line of tests to rule in or out refractory celiac disease. You really have to get in there and get an examination. And that's why I absolutely love swallowing the camera to get an incredible view of the small intestine. I push for it. I push for it aggressively, particularly when I'm looking at genetics, and I do different types of genetics. I'll look at like heterozygosity for individuals that may have risk factors for inflammatory bowel disease, meaning they have one or they can have two of different types of polymorphism genes for a gene that puts them at a greater risk for inflammatory bowel disease in addition to celiac disease genes. And I just start being really aggressive to make sure that I'm getting these tests done. But
and
that's
there's
the real
no way for them to feel these ulcers in their small intestine, correct? It's just like, oh, I don't really feel great. Something doesn't feel right.
Yeah, and they all completely link up with the categories of gastrointestinal symptoms for classic celiac disease. So all of those gastrointestinal symptoms, that's what it feels like when you have this type of ulcerative gingivitis. So it's so sad not to take that step and push for another endoscopy and definitely a camera swallow, especially if you can't get your physical camera in far enough, which sometimes happens. There's inflammation and you can't even enter, and that's a dead giveaway too, by the way. But you still need evidence, and this is where we can get it in an easier fashion and less stressful for the patient.
So what is it that's causing the refractory celiac disease? Obviously, they have to be consuming gluten somehow, somewhere. Otherwise, it wouldn't be the case, right?
No, sadly, yeah. It's really scary. It's really scary. So sadly, we're not fully sure what exactly is causing refractory celiac disease in this celiac disease population. And by the way, I should have said this when we talked about prevalence, Lexi, and I apologize to you. We are hearing that it is slowly starting to increase, which is why I stated while 1.5 is being reported, I'm actually going up to 2%. Is really my humble opinion that I'm starting to see now. So I can at least thankfully look you in the eye and tell you exactly what is going wrong, right? So in classic celiac disease, T cells that are so aggressive against gliadin, when we talk about that, right? They're involved in the pathology. They become inactive when you're on a strict gluten-free diet. So we can measure individuals and see their normal immune system response, because you have to have the intestinal T cells go buck wild in classic celiac disease to have the other markers. We talked about one last week. We talked about that tissue transglutaminase. You have to have those T cells start. Even if you have a different antibody present, the T cells are still the driving force, right? So in refractory celiac disease, intestinal T cells are still active, even with gluten elimination. And that, what does that result in? Continued destruction of the villi and microvilli. Now, other evidence suggests that refractory celiac disease, there's this cytokine, and we're talking about that a lot lately. And everybody, I think, is aware of what they are because of the COVID-19 going on in the news. But there's a cytokine called Interleukin 15, and it's a very pro-inflammatory cytokine. Fun fact, I actually measure polymorphisms of that cytokine. I actually measure polymorphisms of a lot of cytokines. It's just who I am and what I do in my very direct pinpoint type of work. So this pro-inflammatory cytokine, interleukin 15, stimulates the production of interferon gamma, and that can increase the attack of what's known as intraepithelial lymphocytes. Lymphocytes that are inside the epithelial tissue in the cells that line the small intestine, and that goes against and attacking the small intestine and the villi and microvilli. So summing up what I said, where I was breaking up my dialogue, T cell stimulation doesn't stop. That then gets on the phone and says, hey, interleukin 15, we got a serious problem that's not stopping here. Please call in interferon gamma, because that's just going to bring in all the troops and we're going to go to nuclear war. And then that drives the intraepithelial lymphocytes against the intestine for all-out attack. So, and then sadly, all of what I just said, if that doesn't stop, that's a recipe for intestinal lymphoma, or in English, intestinal cancer.
So how is this treated? If it's not the person is consuming gluten in their diet, it's just their immune system is attacking their small intestine despite removing gluten in the irritant, what do you do to fix it?
Yeah, it's really rough. And that's why I think it's this genetic morphed version of celiac disease. And I will pepper in, I'm going to give you the straight lace version of what we do in the medical environment, and then what I believe very strongly in, being a practitioner, having the disease, studying it, writing and publishing papers on it. And I'm never going to stop being a patient advocate for those with my disease. And of course, this is under that title as well, refractory celiac disease. So number one, the primary course of treatment is steroid therapy. So the patient is put on very powerful anti-inflammatories to try to knock out this massive aforementioned immune system reaction, along with, and let me make this very clear, extremely militant gluten-free diet. Like basically, oh my God, you think I'm strict when it comes to celiac disease? Oh, Lexi, with refractory celiac disease, I'm so sorry. What I say to patients is, look, you know, and this is a good time if I happen to have one in my life, because I would say to them, I don't want you eating outside your house for 1 year. I want everything you put in your mouth to nourish yourself to be prepared in your own kitchen. And that may sound quite crazy, but guess what? If you get to me with this type of condition, you are jumping up and down saying, yes, doctor, whatever I need to do, because it's extremely serious. And we are on a very, very fast track towards small intestinal cancers, which you do not want because they spread like wildfire through other areas of the body. So that's step one. Step two, typically we have patients that are also on other immunosuppressive drugs. And believe it or not, Lexi, and I know this is going to blow your mind, but I've seen it and I've worked with it and it scares me. But you know, when you're desperate in a case, desperate times, desperate measures that at least are medically sound, and you have some data, chemotherapy has been used along with some other medications. Wow. That's been used in a research setting, just to do everything you can to really calm down the aggressive immune system response, even if it's pre-cancer situations happening, and non-cancer at all is what I'm referring to. Chemotherapy used in refractory celiac disease that's not controlled, even when there's no cancer present. Some patients have been put on what's called an elemental diet. We've never talked about this before, and that was actually one of the ones I was excited. The reason I wanted to do this topic today was this case I just concluded. This patient was put on an elemental diet, which is basically a liquid diet that requires zero digestion. It is just components. It's the nutrients, vitamins, minerals, triglycerides, which are broken down fats, amino acids, just nothing that requires digestive
Everything
energy.
is pre-unfolded, pre-broken down, ready to be
Yeah.
absorbed.
Yeah, and it's used to bypass digestion and hopefully treat or prevent malnutrition in these extreme cases. Because as you can imagine, if you're just beating up your small intestine and where you absorb all your nutrients, you probably are thinking in your mind, because we talk about this stuff all the time, well, whoa, a lot of the symptoms associated with the complaint list have to be due to malnutrition. And that's 100% correct. And this is where medical doctors that may not be fully aware of or support of identifying celiac disease malnutrition, they just think going gluten-free will resolve that in due course. This is a case where they're hyper aggressive on, we need to fix this immediately. Let's put the individual on an elemental diet and really take the stress off the gastrointestinal tract. And another point is, in addition to that, I've had patients that are just on what's known as total parenteral nutrition. TPN is the abbreviation. That's nutrition supplementation entirely by intravenous methods.
So you're out eating.
No eating, it's bypassing. And I've worked on multiple of those cases. Sometimes non-gastro routes are used as well. But definitely intravenous is the most well and popular known one. And in graduate school, I had to calculate TPN for so many difficult cases. You really ideally don't want someone to get TPN. There's so many changes that happen in the gastrointestinal tract when you bypass it.
I can imagine. When you shut it down completely and be like, you don't have to work anymore. We're going to give you everything that you need.
Can you imagine? That was a brilliant point. It's as if you said, I'm not going to work out my left deltoid and bicep at all for the next 6 months. Imagine that. So that the muscularis is the wave-like contractions of the gastrointestinal tract that are responsible to move stuff through the gut and out through elimination. That becomes flaccid. You then have a change of the guard of good probiotics, bad bacteria, prebiotics no longer there. It is an absolute train wreck. You even have a recipe risk for Clostridial difficile, which is a bad overgrowth of bacteria that throughout Canada it happened several years ago and was wiping out the elderly. It's a very, very serious thing that happens. So this is kind of like, I'm a fan of last resort for this. And that's where I come in for my point. I am absolutely 100% convinced, and no one can tell me I'm wrong, because I'm seeing it on a regular basis where I'm solving these cases, of identifying secondary intolerances, sensitivities, and true allergies that happen in concert in these types of cases. Please understand that the Mayo Clinic went on the record to say fructose intolerance, if severe enough, could actually mimic refractory celiac disease in a celiac disease patient that's not getting better.
And fructose is a very common, naturally occurring sugar found in fruits.
Mm-hmm. Lexi, get this. I had a case of true genetic, I tracked it down all the way through, true genetic lactose intolerance in a celiac disease patient that was told they were refractory celiac disease. Can you imagine how dangerous lactose intolerance can be, where you're still having T-cell activation even though you're gluten-free? Why? They were still so severely immunologically reacting to lactose. It was creating this T-cell stimulates interleukin 15, stimulates gamma globulin, stimulates intraepithelial lymphocytes. Boom, intestinal destruction. So be a sleuth and start identifying in every way known to man. And you should really see how robust my work is getting now. We might need to do an updated podcast on it. I'm looking at everything, down to the spices, the seasonings, the thing you breathe, the artificial colors. What in your diet are you reacting to? The other ingredients, the excipients in your medication. Could you be reacting to those things? And then I identify all the immunological reasons why that transpires. And by the way, there's a whole history of publications that I'm relying on that are saying this, but yet major groups are saying we don't need to look there, right? One of my favorite correlations always, and it's the first thing I discuss, and I just discussed it when I met the patient, and I discussed it last night with the concluding physician, where we basically were kind of, I'm so sorry, but we were patting ourselves in the back for a moment, only from exhaustion, and we were so happy we helped the patient. Zero arrogance. I worship at the scientific method table. That's all I can say, right? I'm never going to know enough. Is I always bring up a condition known as eosinophilic esophagitis. And that's where this type of white blood cell known as eosinophils can start attacking epithelial tissue. And if you look deep in the literature from awesome medical journals like Nature, they always say it is a non-IgE immune system mediated reaction behind it.
which
So
means
then
it is a non-allergic reaction. So you're not allergic, but your body is negatively attacking the
yep,
food
yeah.
that you're introducing to it.
Yeah, and then beating you up in the process. So in this case that I'm discussing, it's very serious. I actually have a battery of patients that I've been working on for years, and I have several under my wing right now, and I'm tracking down every single causation of it. In that case, not to get off topic, but in that case, these eosinophils get into the esophagus, which has no protection. It's epithelial tissue. There's a lower esophageal sphincter that keeps our acids and irritants out and in the stomach. It should. And then that pops open and you have all this immunology getting in there and damaging the tissue. And much like what I'm talking about with refractory celiac disease that can lead to different lymphomas, this leads to a condition called Barrett's esophagus, which is a precancerous condition of the epithelial lining. And it's all caused by food reactions. So in all of these cases, I deep in my heart believe, and specifically here I'm referring to refractory celiac disease, you have to go militant crazy to identify all, of course, IgE, but then all non-IgE mediated reactions, which includes everything you could think of, including the American Academy of Allergies skin scratch test in a physician's office while the patient's consuming a food and making sure they're not going to go anaphylactic, so you at least can identify what's known as a mast cell histamine response. And that's just a really quick immune system reaction. But I'm saying you have to turn every stone over and make sure you're not missing it. And I will use genetics, blood, and scratch tests in an allergist office to get an enormous amount of data to then present my findings to the physician team and to the patient themselves.
And I want to go back to one of the episodes that we did earlier this year on lactose intolerance and the celiac connection. And you mentioned there that one of the studies had reported 1 in 4 people that were celiac also had lactose intolerance. So in your practice and all the patients that you've seen, how many of them have come to you with what they thought was refractory celiac disease, where it was they were consuming a food besides gluten that they negatively reacted to?
I fixed every single case of refractory celiac disease that landed on my desk.
100%.
100%.
Wow.
I've always been able to identify what was the causing reaction. And in this case, that was wrapped up with small intestinal bacterial overgrowth, which, by the way, if you look that up in proper medical locations, that will pop up as, yep, that's it. But to really do that, you've got to get in there with a biopsy. But simultaneously, this individual was lactose intolerant and had an immunoglobulin reaction to dairy. And without me doing what I needed to do, I never would have been able to close that case. So you may say, well, what was the treatment in that case? I loved this answer. It was 14 days of Xifaxane, which is a powerful antibiotic that stays in the gastrointestinal tract and does not get absorbed very well into the bloodstream. I think less than 1%. It's just awesome at treating localized small intestinal bacterial overgrowth, followed by very strong pharmaceutical grade probiotics. And the gastroenterologist took the lead there and actually prescribed something that he had in his office. And he's militantly, academically MD trained GI, great friend of mine for at least 10 years. And then I did a full-blown identification, proof of non-IgE mediated reactions, and elimination. And we had our resolution. So I always find in refractory celiac disease that there is a food-mediated reaction transpiring at the same time, and there could be other conditions that are behind the true diagnosis. Like one of the cases that is also fresh, but not as recent as the one I just concluded, was a case of microscopic colitis, which, as you can imagine, is quite difficult to get. And what's also vexing is I saw it when I did my reach to get old data as part of what you're supposed to do, right? And then I said, wait a minute, I'm going to call a friend on this. I'm seeing microscopic colitis. Why is that not on the report? It's just celiac disease. So there's actually 2 things happening at the same time. So that patient was managed with a short-term course of some medications. It was Pentasa in that case, which is known as 6-NP. And that individual helped neutralize a crazy immune system response, while I was able to simultaneously identify the other foods that the individual was intolerant of and close that case.
Amazing. So a diagnosed celiac believes that after 1 year of following a militantly gluten-free diet that they're still not feeling better and they think that something is up what should they do when they go to their physician? Because we've talked about this time and time again, that physicians are very new to the understanding and recent studies and knowledge that's coming out on celiac disease. So in order for them to help their physician help them, what should they do?
You just lit a fire under me, and you know how busy I am, and it's happening. I won't let it pass. This is now going to be a blog that the individual is going to print out and they're going to hand to their doctor. And first and foremost, it's going to have the 6 first steps they should do, where they have an intense, if you don't mind, I'll summarize, an intense record review. Please go back to the beginning of the episode to hear how in-depth I was. An intense record review, double down on identifying any other causations, making sure there's an endoscopy and colonoscopy with biopsies. Please inquire if you can have a capsule endoscopy, swallow a camera. See if there's any risk and the physician is concerned for lymphomas. Should I swallow barium and have an x-ray? Should I get a CT scan along with that? Do we need a magnetic resonance enterography to fully see my anatomy? Lastly, should we see if there's any fecal fat issues with my fat digestion, which is not very normal? Should we see my pancreatic output? Is that actually functioning optimally as well? Your standard physician can refer directly into your gastroenterologist, and all of that can be done and literally set up right in a row in syncope, so we're not losing time. And then if I may be so bold, I would absolutely see someone that is an expert in identifying and tracking down every single way of finding a true immediate IgE immunoglobulin reaction, a mast cell histamine response, mast cell reaction in a physician's office through a skin scratch test, and a battery of blood work that can help identify non-IgE immunoglobulin reactions. And it's very specific to the case. It could be whatever your needs are. You need to speak to someone who's very knowledgeable in that and let them grill you and then talk with you and come up with a battle plan. Sometimes I'll look at IgAs against certain foods if my patient's so robust in IgAs. Sometimes I'll look at IgG4s, and while they're so controversial, you know what's not controversial? Taking a patient that was dying and having them not. That is awesome. And so that to me is like just being really smart and practicing what I like to call smart medicine, smart science, right? So doing all that, I think is just absolutely so critical in those cases. And don't give up, find those intolerances. But really, this is a point where you have to go very, very deep, and it's extremely difficult to do on your own, because if you do have any of that ulcerations in your gastrointestinal tract, we don't have time on our side for an elimination diet and testing the waters. You're a raw nerve. Salt is going to hurt you. Pepper, water is going to feel ouchy in your gut, right? So let's really be militant about identifying everything.
And we will include not only the 6 steps for your physician, but also the recommended tests for food reactions, whether they are allergies or immunological reactions, because there is a difference between the two. All of that will be in the show notes. But if your physician is still confused and lost and they're not 100% sure, either 1, get a new doctor, or 2, provide them with Dr. Pastore's contact information. drrobertpastore.com. He's on social at Dr. Robert Pastore, and he can have a conversation with your doctor to help you. He's here. He's done it many times for listeners that have reached out in the past, for people that support him and the work that he does, and he just wants to pay it forward. So do not be afraid to ask for help.
All the time. I do it all the time. Yesterday, my day was just talking to doctors and just telling them what the patient needed. And yesterday I had one of the coolest things happen. Just a brilliant, awesome Ivy League physician said, "Hey, this is awesome. I'm actually learning something new." That's the beauty of medicine. And that made my day, because what is the end game? Getting that person well, period.
And
there's no egos.
One physician for one patient, they can then help 10, 15, 100, however many others.
That's the goal. That is the goal. And I will absolutely, my word, have this blog done so we can have that published as quickly as possible, so that we can share this. And it'll be in a very easy to read format, so it could be printed and shared with your physician. If unfortunately you are experiencing this, and I'm sorry if you are, or a loved one, please do that. This is based on a very years of experience and a lot of graduate education.
So we hope that you found this episode insightful and you learned something. And if you or someone that you know is experiencing the symptoms of refractory celiac disease, share this with them, share the blog with them, and we are always here to help. So thanks so much for listening, and we will see you next week on the Pastore podcast.
Thank you.